John, thank you so much for taking the time to share a few thoughts about AI while we're here at Health. I know that your job is to touch the lives of 4 billion people. So how is that going?
Well, so when you look at the number of patients in the world that have electronic health data, and you look at the countries that have regulatory frameworks that are friendly and political stability, it's about 21 countries. And so country by country, you say, well, how do we empower and scale digital health? It all starts with data. And the challenge, of course, every country has different regulatory frameworks, but also different cultural expectations about how data of the past can be used for the future. So my role, traveling the world, 21 countries this year, helping at country scale answer the question of ethical, privacy-protected reuse of data so the patients of the future benefit from the patients of the past. So far, so good.
We see in the US that there's a lot of kind of connectivity of data or creating data pools for research. So there's Epic Cosmos, there's Komodo Health, there's the Mayo Clinic Platform that goes even beyond the US border. So you're connected with Brazilians, with Koreans, with others. So I wonder, in the EU, we're currently in the middle of the EU AI Act, trying to figure out how we're going to manage data. There's GDPR. What's your perspective with all your travels and all your knowledge also, by building and being the president of the Mayo Clinic Platform?
Well, sure. Well, I love all countries equally. But as you ask, where are countries willing to take risk and work at large scale and move rapidly? I would say Denmark, Netherlands, Sweden. And of course, we're in the Netherlands today. Tonight, I'll be in Sweden. And it's meeting at government levels to say, what's the right organizing principle? Is it a medical center? Is it a region? Is it a country? And recognize GDPR is not a restriction to the secondary use of data. It tells us how. The EUA law doesn't prohibit the use of AI. It gives us guardrails and guidelines. So I would say certainly Europe is moving fast. The US is innovating quickly with technology. And there have been several regulatory and non-regulatory approaches to building guidance around AI, like the Coalition for Help AI. And so I think our job, because no one has the right answer, is to just work together. And if anything, my job is about building the togetherness.
You often emphasize, or I heard you say at Health in Las Vegas, that when it comes to generative AI, which has been all the hype in the last 12 months, the challenge is that when the output is different every time, how do you actually regulate that? What's new in this field? So in the field of figuring out what's the best way to validate and regulate generative AI in healthcare?
Right. Well, two approaches. First, we know it's going to have hallucinations. It's going to have some answers not so good. So what's the risk? So imagine that we decide on a use case, the summary of your historical record so I can read it more easily. Okay, if it's inaccurate, it's probably not going to do a huge amount of harm. If, on the other hand, we say generative AI, decide on your treatment plan, that could do real harm. So first issue is look at the risks of every use case and go forward with those administrative, low-risk, high-yield use cases. And that's happening now. Second, we're going to need a credibility score because it may very well be, as we said, one moment the answer is brilliant, the next moment the answer is horrible. So you need to assign a numeric credibility score because if the answer is bad, then another prompt might be in order. And companies are starting to build credibility measures, quality measures for generative AI.
If I'm not mistaken, the Mayo Clinic uses around 240 algorithms, right?
So at the moment, we have about 250 predictive algorithms, all validated, many through FDA and CE. But we have 8 major generative AI projects. Those are all being done under a research framework because, as I say, generative AI, useful, may not be ready to be sort of given directly to patients at this point.
In June 2024, we're crossing the hype on the tallest possible point. So we're kind of decreasing the expectations a little bit. So what kind of use cases do you have at the Mayo Clinic for AI and generative AI? So if you had to cluster all those 250 algorithms, like is it 50% for administrative things? How many of them are used for diagnostics. And now we're talking just AI generally.
Well, right. And so I have a slide which goes through this in detail. But if you were to look at that slide, it's a wheel. And on the wheel, you'll see about half are administrative in nature. Supply chain, revenue cycle, workflow enhancement, staff augmentation. Then we go into fields like cardiology, early diagnosis of disease, prediction of cancer, assessment of neurology like Parkinsonism or other neuromuscular diseases, radiation oncology, planning treatment. So you've got a whole variety of clinical use cases, but that's predictive AI. The world of generative AI, such things as summarizing a record, writing a discharge summary, helping with nursing notes, helping interpret genomes. And one speculative early project is, can we predict a patient's journey, looking at hundreds of millions of patients and every event in their lives? What's next for you? Do you need a lab test, a visit, a surgery? We're just starting on that journey.
If I go back to the Mayo Clinic Platform, so I mentioned earlier that you're connected to other countries, to institutions from other countries, and the platform works based on the federated approach.
Exactly.
And can you talk a little bit about the validation of algorithms? So oftentimes it happens that basically there's data drift, that the algorithms are not applicable to different institutions if they're designed in one institution. So I really wonder, when you even go cross borders and you actually have a different population, a different race, what does that mean for algorithm validation, and how do you even fine-tune that then?
Right. So on the one hand, you could say, I want to look at an algorithm and how is it generated? What's its data card and model card? And that's great. You can at least get a sense of, is this algorithm following good hygiene and good process? But every algorithm needs local tuning. So to your point, Mayo Clinic in Minnesota may not have a very large population of Slovenians. And so what would you need to do? Well, validate the algorithm as having been put together in a reasonable fashion, but then take it to a Slovenian data set and then assess how well does it work on subgroups of that population, and then tune it from there. So that's why our very federated approach is, yes, validate overall process, but then also locally tune.
And what are the biggest challenges in this regard so far when you're testing the models? What are your observations currently of basically the federated approach to using or scaling algorithms?
Right. Well, it has to start with data curation, right? So the data in healthcare we gather is not very clean. And so the first step, and it takes 9 to 12 months, is to turn the data that was gathered for transactional purposes, medical care, into highly organized, vocabulary-controlled data for AI algorithms in a privacy-controlled environment. So data cleanup and curation is the hardest part.
Absolutely. So if I understand correctly, do you actually, when you connect different institutions, is this just for research purposes? So you take a specific, data in a specific time and then try to clean it so it's comparable, and then you kind of test and try to get research results based on that data?
Well, and the answer is for many different use cases. The data is never sold. The data is never exfiltrated. It doesn't leave an organization or a country. The data may be used for research. Is this drug safe? Is there a new treatment protocol? But it's also used for creation of products and services like novel algorithms that will then be used in the marketplace, or validation of algorithms so that they can go through a regulatory process. So it's used for both.
Okay. In this whole story, and especially with the generative AI and new AI approaches to structuring data or even coding the data, where do you see the role of data standards in healthcare? How do you see them working together in the future?
Sure. Whenever I talk about standards, I talk about three kinds: content, vocabulary, and transport. So a content standard, how are we going to store data at rest? Very clear internationally that OMOP and extensions to OMOP from Odyssey are the way to store data at rest. And I see country after country moving to an OMOP model. Vocabularies, SNOMED for descriptions of medical observations, LOINC for labs. Then there are other country-specific standards like RX norm for pharmaceuticals, or various kinds of World Health Organization standards for codifying demographics. But there's a set of vocabulary standards commonly in use globally. And then for moving data from place to place, FHIR. And FHIR R4 and R5 normative editions. So the great news in 2024, the number of data standards that we have is much, much fewer than we used to have and more generally accepted.
Maybe just one last question. So you travel a lot. What are your general observations in terms of how AI in healthcare is developing? Is there something specific that you saw recently that kind of inspired you? Because we do tend to look at the US, especially from Europe, as far as progress goes and progressiveness, yeah.
Well, but I think two observations. Most countries that I visit have birth rates less than 1.5, which means fewer babies born, means fewer doctors and nurses, but yet they're aging societies. People are living longer and needing more services. Every country is saying, unless we have AI that will extend our existing workforce or refine our existing capacity to deliver care, we're never going to make it through this demographic shift. So that's, I think, observation one. Observation two is every country has what I'll call a Gaussian distribution of adoption. There are those who say, give me AI today, I'm willing to take the risk. And others that say, oh, that's pretty risky. Why don't I wait till someone else does it? And so it's just interesting as I visit country after country, that divide line between those who are early adopters and those who are fast followers is clear at a cultural level.
Is there something such as a common advice or the most common thing that you usually say to governments or hospitals when you meet them and they ask you, we hear a lot about AI, we have no clue what to do with it. So what's your answer to that?
All right. Well, the answer is you need to start on your journey. So it's fine if you have a very low risk tolerance. Well, let's do one hospital. Let's do one algorithm and then build from there once you have trust, once you have a sense of transparency, of consistency and reliability. As I say, because every country is different, but every country is willing to start somewhere. So don't just wait. It's time to move now.